In my experience, there are many situations that can lead to diagnostic errors when performing venous imaging. These errors usually relate to the examiner mistaking non-vascular structures for venous structures, or mistaking non-thrombotic material within the lumen of a vein for thrombosis.
The non-vascular structures most commonly mistaken for venous structures are 1. Lymph nodes, 2. Popliteal or Baker's cysts, 3. Hematomas and abscesses, 4. Nerves, 5. Bowel, and 6. Edema. The non-thrombotic structures identified within the lumen of the vein that can be mistaken for thrombus are 1. Venous catheters, and 2. Valves. Each of these situations will be discussed individually. Lymph nodes are numerous in the extremities and are visible on ultrasound examination. The most easily identified nodes in the lower extremity are the inguinal nodes, which lie in the groin near the femoral vessels. This can be a problem because lymph nodes are enclosed in a dense fibrous capsule that may closely resemble a thrombus-filled vein. They can be differentiated from vascular structures in that they are encapsulated, so that they cannot be followed for any distance while being imaged from a longitudinal scan plane. In fact, they look similar to a vessel being examined from a transverse plane, even when being scanned in a longitudinal plane. Once it has been determined that the structure in question is encapsulated and may be a lymph node rather than a vessel, the femoral vessels are then identified away from the node. Although a lymph node may be very close to the vessels, clear separation between the two structures should be documented. In most cases, the lymph nodes will be so small that they are overlooked during routine examination. However, in the presence of infection, they can become grossly enlarged. When one encounters a large echolucent structure located near the popliteal vessels in the popliteal space, the presence of a Baker's cyst should be suspected. This is especially true when the patient gives a history of degenerative joint disease and sudden onset of pain behind the knee. A Baker's cyst, also commonly known as a popliteal cyst, is a collection of synovial fluid that has been displaced from the popliteal bursa and has formed a new sac posterior to the knee joint. They can be quite painful. Once a suspected cyst is identified, care should be taken to make sure it is not an enlarged vascular structure by identifying the popliteal vessels and noting the separation between the vessels and the cyst.
With further injury, a popliteal cyst may rupture, resulting in fluid leaking into the upper calf. Baker's cysts are a fairly common occurrence, and because differential clinical diagnosis between Baker's cysts and venous thrombosis can be difficult, venous imaging has proven to be a useful tool in sorting out such diagnostic dilemmas.
Following injury to an extremity, an extravascular collection of blood may accumulate. This accumulation of blood, usually clotted, is called a hematoma. The ultrasound appearance of a hematoma will be quite similar to that of a Baker's cyst. It will usually be an echolucent structure, although it may become echogenic. As is the case with lymph nodes and Baker's cysts, spatial separation from the vessels should be documented, and determination of encapsulation should be verified. On occasion, a focal area of pus may be visualized within the tissue that will have the appearance of a hematoma. This is called an abscess. Differentiation between a hematoma and an abscess is not possible from ultrasound information alone, so aspiration is usually necessary to make such a determination. Arteries, veins, and nerves run side by side throughout the extremities. Clear vessels are echolucent, so they stand out during ultrasound examination. Nerves, however, are highly echogenic and blend in quite well with surrounding muscle and connective tissue. For this reason, nerves usually go unnoticed during ultrasound examination of the venous system. However, when being insonated from a transverse view, nerves are sometimes seen and can be mistaken for a vein filled with old thrombus. Differentiation between a thrombus-filled vein and a nerve can be made by rolling longitudinally on the structure and checking for long, bright nerve fibers. If these fibers are visualized, the structure is a nerve. Imaging the iliac vessels is difficult because the veins travel deep and bowel gas limits visualization. Another hazard to imaging of this region is that bowel filled with fecal material can look like a vein that is filled with thrombus. Staying on the structure and watching for peristaltic movement is one way to verify that the bowel is being imaged instead of a vascular structure. Care should be taken in this area to avoid this potential pitfall. In situations such as congestive heart failure, transudation of fluid from the capillaries can result in an excessive accumulation of fluid in the tissue spaces. This trapped fluid, called edema, can be visualized during ultrasonographic examination as a network of fluid-filled spaces near the skin. Edema may be mistaken for small vascular structures, but most often is simply a hindrance to visualization of structures that lie deeper in the ultrasound image. The ultrasound energy is scattered and attenuated by the excessive number of interfaces it encounters passing through the edema, so that structures behind it are poorly visualized. Once you know you are visualizing the vein, you can usually assume any solid echogenic material within the vessel that restricts compression will be thrombus. There are some exceptions, however. The most common non-thrombotic structure that will be encountered during venous imaging is the venous catheter. These catheters are quite common, especially in intensive care unit patients. When encountered during transverse venous imaging examination, the catheter may at first appear to be a small, non-obstructive area of thrombus within the lumen of the vein. It will appear to be very brightly reflective. Differentiation between the presence of thrombus versus catheter can be accomplished by rolling longitudinally. If the structure is a venous catheter, it will have very clean, straight, bright echoes. The line may move back and forth within the lumen when the area around the vessel being imaged is manipulated. In some cases, thrombus can be identified forming on the catheter. The other non-thrombotic structures commonly seen within the lumen of the vein are venous valves. They appear as very thin, delicate projections into the vessel. They are brightly echogenic, but because they are so thin, they can easily be overlooked during venous imaging examination. They present a problem only when they are mistaken for non-obstructive thrombus along the vein wall. When a valve is encountered during transverse scanning, it will appear as a thin white line, usually in motion, that appears within the lumen of the vessel. Because venous valves are bicuspid, two lines may be seen. The examiner should then rotate the probe into a longitudinal approach to visualize the function of the valve. With passive respiration, the valve leaflets will be open, allowing blood to flow toward the heart. Then the patient should be asked to perform a Valsalva maneuver. The examiner should then observe the vein leaflets as they close as the patient bears down. These observations verify that the structures being visualized are functioning venous valves as opposed to residual venous thrombosis. Of course, damaged valves may be thickened and may not function as described above. This can make differentiation between thrombosis and valve leaflets more difficult. Another potential for error when visualizing valves is that blood can become trapped in the valve cusp and create the appearance of thrombus behind the leaflets. The vein should then be compressed to see if compression will evacuate the blood from behind the cusps.